session, Implementation of a Telephonic-Based Model to Continue to Address Substance Use as a Part of Usual Care, features Dr. Sandeep Kapoor from Northwell Health. We do want to give a sincere thank you to all of our past sponsors. This is the 6th year of the North Country Telehealth Conference, and it would not have been possible all of those years without the organizations represented on this slide. We truly hope that next year we can meet in person and you will have the chance to browse the exhibit hall and see what many of these organizations and vendors have to offer. And I'm just waiting for the next slide to come up. Oh. Okay, so a few housekeeping items before we kick off today's session. You've all been muted upon entry and your video has been turned off, but just please remember to keep yourself muted throughout the session. In terms of Q&A, we are going to hold questions until the end. Please submit your questions through the chat box, and we are not unmuting any lines. To avoid an echo on your end, just from a listening perspective, you will need to make sure that you've either chosen the computer audio option or the phone audio option. For optimal viewing of today's slides, you will want to use side-by-side mode. To activate side-by-side mode, you would click on View Options at the top center of your screen and choose side-by-side mode from the drop-down menu. Again, use chat freely to submit all questions and comments, and AHI staff will ensure that your questions are answered. And lastly, all of our presentations will be recorded and archived on our website by October 9th, as well as the slide deck. So again, if you miss anything, the slide deck and the recording will be put up on our website after the fact. So I'm going to introduce Sandeep. I'm going to stop sharing and let him bring up his slideshow. So Dr. Kapoor is an assistant professor of medicine, emergency medicine, and science education at the Donald and Barbara Zucker School of Medicine at Hofstra/Northwell. He is the Assistant Vice President of Addiction Services for the Northwell Health Emergency Medicine Service Line. And he's the Director of Screening, Brief Intervention, and Referral to Treatment, or SBIRT, at Northwell Health. I'm going to let him kick it off and talk about his implementation of a telephonic-based model to address substance use as part of usual care. Go ahead, Sandeep.
Great. Good morning, everybody. Thank you very much for the honor and the privilege to present today and to open up the conference. I'm going to focus on a disease process that unfortunately there's no 6 degrees of separation, and professionally as well as personally, many of us have been unfortunately touched by and are dealing with. Before I get started, let me just please make it very clear that I'm standing in front of you virtually representing a very large team-based collaborative that spans throughout our health system, both clinical and non-clinical departments, as well as our venues for education in the School of Medicine and the School of Graduate Nursing, but really also with external partners, including New York State and the federal government. And together, over the last 7 years, we've been working to humanize and address substance use as part of usual care. So a little bit about Northwell Health, if I may. We are the largest healthcare organization in New York State. We also are the largest private employer in New York State. And as you can see from the map, our catchment area is pretty much downstate New York. But we have 23 hospitals in our network, and we serve over 2 million patients annually. So if you look at this and look at it from the viewpoint of how my team and myself look at it, this is an amazing petri dish to really test change and to drive change as an industry when it comes to a disease process that unfortunately is hopeless for many. Here at Northwell Health, we do have a layered approach to building a foundation as well as building up a framework to continue to enhance our clinical offerings as well as our care offerings when it comes down to addressing substance use. The best way I can describe it, beyond putting all our logos up there, is really talking about building a house. Over the last 7 years, we built a house of strategies revolving around how do we compassionately support our patients and our 72,000 employees around the topic of substance use. So the best way to build a house, you need a foundation. And for us, our foundation has been something called SBIRT. Not everyone's familiar with this. I will go over it in a little bit detail in a little bit, but it stands for screening, brief intervention, and referral to treatment. Now, it may sound like an alien kind of project just on first pass, but if you really think about how we take everybody's blood pressure every time we see them, that is screening. And if we have a conversation about their nutrition or their weight or medications for hypertension or hypotension, well, that's a brief intervention. And then if we need to refer out to cardiology, that would be a referral to treatment. So everyone here understands what SBIRT is when it comes to cardiovascular disease. We had the privilege of implementing the same exact model when it comes to a chronic condition like substance use disorder. Our second layer of this house of strategies is the floor. And this takes shape and form in our NowSat program, which is our naloxone saturation campaign. Pretty much what we've done is stood up an avenue to educate patients, families, and staff members on how to prevent fatal opioid overdoses by using the antidote known as Narcan or naloxone and dispensing the rescue medication free of charge at point of service. Thank you to partnership with New York State Department of Health. So we do this throughout our health system to ensure that we are talking about opioid overdoses and how every single one of them is preventable. The third layer, our stairs, is actually offering the initiation of medications for addiction treatment. So when it comes down to it, this is a chronic condition, which substance use disorder represents, and many chronic conditions have medications available. So instead of just relying on our addiction treatment facilities, we've started to initiate medications for addiction treatment within emergency medicine, as well as ambulatory, as well as inpatient settings, so that there's no delay in the care and the treatment of this disease process. Layer 4, our roof. So if we look at our houses, our roofs keep us safe, it keeps us warm, it keeps everything together. And our illustration of the roof for this house of strategies is Project Connect. And the reason why I want to share this with you is because in the framing of substance use disorder being a chronic condition, well then patients dealing with the chronic condition may benefit from chronic care navigation. Project Connect, working with an external community-based organization, allows just that. We supply and provide an advocate, a champion, pretty much a best friend for that patient and family for up to 120 plus days, so that they're not navigating the landscape of addiction care on their own. And then lastly, the framing of this house really is deep rooted in education. And I'm going to share a couple of slides to you of why education is so important. But through our School of Medicine and School of Graduate Nursing, and now within our residency programs and even our faculty development, we have developed and infused tremendous amount of educational opportunities when it comes down to addressing substance use as part of usual care. So today really is about seeking opportunities, identifying opportunities, and really, as everyone on this call is a healthcare professional, regardless if you're clinical or not, there are a tremendous amount of opportunities available when it comes to this space. One of the things that we've been talking about as a health system for the last 7 years is that no matter what system level strategy or department level strategy or community level strategy that we're trying to stand up, unless each one of us as individuals, as individual healthcare professionals, as a neighbor, as a member of our community, is willing to diversify our personal approach around this topic in particular, a topic that's highly stigmatized, a topic that's hidden under our dining room tables because we do not openly speak of it. Well, if we're not going to be committed to personally diversify our approaches, then every system level, every community level, every industry level strategy will fail. So with that said, I'm going to ask your close attention for the next 9 minutes as I walk you through an opportunity for self-reflection as the individual you are, an opportunity for self-reflection as the healthcare professional you are, as well as an opportunity as the leader you are in this industry, within your organization, within your department, to look at substance use in a different way, to reframe the conversation and give us all a moment to pause and think, what can we do differently? And in the world of telehealth, this is a really important conversation for us to have now, because as telehealth continues to evolve at such a fast pace, we need to ensure that our communities, our patients, and our families aren't left to fend for themselves when it comes to a disease process that telehealth and tele-based solutions can actually support. So when my team and I talk about substance use, unfortunately, many of us jump to the far end of the spectrum and all we think about is abuse. And our conversations change very quickly and we start using words that alienate the individuals that may be dealing with the chronic condition. We use words that cut so deep that it perpetuates the stigma through our addressing or through our approach. Dr. Martin Luther King said, life's most persistent and urgent question is, what are you doing for others? Now, as a room or a virtual room full of healthcare professionals, we do a lot for others. But if you replace the word others for a moment with folks dealing with substance use issues, that's a much difficult question to answer personally, professionally, and potentially as an industry. But we need to ask ourselves that question because the issue is stark. 1 in 4 people that started using alcohol, drugs, and tobacco before the age of 18 currently have a substance use issue, leaving 40 million of us dealing with a substance use issue that is overshadowing the prevalence of 3 of the largest chronic conditions that even my 9-year-old can speak of. The cost to society is enormous. When you combine heart disease, diabetes, and cancer, we're at $775 billion. However, when you look at substance use, including tobacco, we are not far behind at $706 billion, though this is still not served as a driver towards change. Education. So the average physician in this country has received less than 4 hours of dedicated education in medical school, leaving our residents feeling unprepared. Our nursing schools, unfortunately, also haven't met the demand, and 98% of master social work programs as of 2017 still did not require a course of substance use. And what happens here is that 1 in 10 people, as a result of our lack of education, receive the treatment that they really need. Only 1 in 10. And the majority of people that do don't stem from healthcare providers. Less than 7% of folks that receive treatment stemmed from their healthcare provider. The majority of referrals come from the criminal justice system, which is its own issue on its own. So when we were looking at this, we figured out there's a 3-part recipe here. We need to educate folks so that we can garner motivation and build comfort so every one of our 72,000 employees can serve as a conduit of hope for a disease process that unfortunately is hopeless to many. Now, one of the things that we did to start this process is really look at the way we speak. Now, everybody knows throughout New York and this country that there is an opioid epidemic. However, we keep talking about the opioid epidemic as if it's somebody else's. But if we reframe our verbiage and call it our opioid epidemic, instantly, everyone on this call has ownership and shared accountability. And we need to be accountable. In 2019, we lost over 68,000 people to drug-related overdoses. That's more than 20 years of the Vietnam War combined. And 2017 and 2018 were no different. New York State in particular, we have more drug-related overdoses than suicide, homicides, and car accidents combined. The problem is we keep playing this blame game as an industry. We know there's many players, big pharma, the individuals, hospitals, the pharmacies, Press Ganey, the federal government, the criminal justice system. But as we're playing this blame game, all we're doing is confusing the situation and really leaving ourselves to fend for ourselves. Let me explain this blame game for a moment. The lack of accountability underscores the lack of ownership, which perpetuates what we're seeing is a lack of motivation, and unfortunately fosters what we see around this industry is a lack of action. We need to stop playing the blame game and just stand up and take accountability, because we can act. We can motivate a shift in our culture by looking at substance use as the healthcare issue it truly is. We can make a shared commitment to enhance our skill sets, to enhance our awareness, and best yet, enhance our comfort so we can bring an element of comfortability to a topic that's very uncomfortable for many. We also have to come to some realizations. Yes, there may be a face to addiction in our minds, but the reality is it could be any one of us. There is no face to addiction. And the majority of people that may be dealing with the substance use disorder are at risk, not necessarily diagnosed. So we can look at this from a public health perspective. One way to do it is look at it just like we look at other diseases. Type 2 diabetes, for example. We all know there's a journey before an adult is diagnosed with type 2 diabetes. And from pediatrics to geriatrics, we screen, we intervene, and we treat that patient based on where they are on that journey. Substance use should not be viewed differently. Not everybody is dealing with a substance use disorder, but we are somewhere along the spectrum. And if we were to take advantage of every single touch point to screen, intervene, and potentially treat or refer to treatment, we can stop the progression of this journey. We can stop the progression of that disease process. Another realization is that there really is help and recovery is achievable. 21 million people are in recovery. And with the mindset that you, as a healthcare professional, can be that conduit for care or treatment just by starting off with a compassionate conversation, well, then there is hope. Another realization is that there's a landscape of addiction treatment, not just rehab and detox. And if we start coming to this realization that there's tremendous amount of outpatient care available and supports available, well, then we know where a starting point could be for a patient in need, as opposed to feeling like failures when we can't get them to the top level of care. One last realization I want to highlight is that that recovery is not a straight line. Though our expectation may be, we know very well, even when we make our own changes in lives, that we may falter or we may slip. And if we bring compassion and understanding to this equation, well, then we won't shut down on our patients. And it'll actually fuel us to use more person-centric language, not to shame people, but to really avoid judgment. Think about the words we use right now. We use addict, alcoholic. We talk about a urine drug screen being dirty or clean. These are very derogatory terms that can be easily replaced with person-centric terminology. Folks, we do have a lot of power in this equation. And again, in the telehealth world, it's really important for us to think, if we can reframe this conversation, we can act, we can advocate, we can make significant changes. And though there's many challenges, every challenge is an opportunity. I promise you that. It's an opportunity for you, my family, your family, our communities, and our industry at large. So with that said, I just want to make sure that we're very clear, especially in the environment we're living in right now. Though the substance use epidemic is currently affecting all demographics, historically, and we all know this, it has affected certain communities more than others, especially communities of color. Now, we cannot just avoid that, but we need to use that as motivation. It should fuel us to act, to partner, to innovate, to correct, so that we now can provide care and social justice indiscriminately. It's our time to right the wrongs of the past. And when we think about telehealth, a lot of this is about access. And for folks that are on the lower socioeconomic status or don't have access to care, it's our time to start dissipating and mitigating that despair and hopelessness and replace it with compassion and equity. We have the ability to eliminate disparities in care and justice by ensuring that we don't forget about substance use disorder and substance use when we're thinking about standing up tele-based solutions. So our goal has been using a compass that's deep-stewed in humanism, compassion, acceptance, respect, empathy, and justice. And together, we're hopeful that our state, as well as everyone around this country, can work together to start communicating in a humanistic way about this subject, to destigmatize this disease process, to disrupt the industry norms that we've been forced to follow, accept substance use as a healthcare issue, build partnership amongst each other, our patients, our communities, and finally stand up as an industry that serves as a conduit of hope for a disease process that unfortunately is hopeless to many. Thank you for that. I know, if we were in the same room right now, I would ask everybody to close your eyes and, just thinking about being on Zoom and being in your own environment, I'm still going to ask you guys. I'm going to ask you guys just for one moment, make a pause in your day, close your eyes. And as your eyes are closed, I just want you to think of that one person, that one family, that one patient, whoever it may be, that may be struggling with a substance use issue, and just think about what you could do differently for them. I appreciate you guys taking that moment. I'm going to continue on with the presentation, but I will say I wish personally I asked myself that question on a daily basis. Like I mentioned before, there's no 6 degrees of separation, and many of us have lost loved ones throughout the years to this disease process. And I do stand committed in front of you when I say that there are opportunities available for us to do things differently. So let's just go back for a moment to the House of Strategies and dive in a little bit deeper. So our foundation, like I mentioned before, is SBIRT, which is Screening, Brief Intervention, Referral to Treatment. We had the privilege to work with New York State and the federal government. We received a grant about 7 years ago to stand up universal screening, understand how alcohol, drugs, and tobacco may be affecting a patient's life, both health-related as well as psychosocial. The SBIRT process is broken down into screening, brief intervention, and referral to treatment. So the screening, at least at Northwell Health, starts off with a pre-screening, meaning 2 to 4 questions are asked of every single patient, pretty much at every single entry point in our health system. We ask them during a primary nursing assessment or an ambulatory care. Our medical office assistants do this part of their primary assessment. And really what they're trying to gauge is if that patient is, based on their self-report, is at risk of a substance use disorder, really understanding what part of that spectrum that person is based on their self-report. The next step is a fuller screen. So it's a team-based approach. Somebody else on the team, it may be a health coach or a social worker or the physician or nurse. They will do a more fuller screen, again, evidence-based tool to really better risk stratify where that patient is. So it's kind of, if you guys are familiar with the PHQ-2 and 9, this is the same model, except it's for substance use in particular. PHQ-2 and 9 is for depression. The brief intervention, and I'm going to go over this in a moment, that's our opportunity. And I'm going to frame it this way. It's our opportunity as a healthcare team, as well as it's an opportunity for our patient to have a thoughtful conversation to understand if there are consequences of that person's substance use. And if there are consequences, is there any element of that patient's life, meaning any change that they could put into play that could make their quality of life or their health better? It's not about driving our agenda. It really is understanding what the patient's agenda is, meeting them where they're at, and trying to support them. Now, some folks, 5 to 10%, may be on the far end of that spectrum dealing with a substance use disorder. And at that point, either we will start treatment, like I mentioned, or we will refer out to our colleagues in addiction treatment that is supported by New York State OASIS. So here are the pre-screen questions. Like I mentioned, it's 2 or 4 questions, because if the first question for alcohol is responded to as never, the other 2 don't even populate. These are built into our electronic health records. It's part of our workflow. We have metrics around this. We report back to the sites. They understand where they're at with screening their patients that may be dealing with substance use issues. And I want to highlight, this is a universal approach. You could stub your toe, you can come in with a cough, you can come in with chest pain. It does not make a difference. If you are able to be screened, we're going to ask you, just like we ask everyone, if alcohol, drugs, and tobacco are playing a role in your life. We've completed, or we've provided over 1.75 million opportunities in the past 7 years. And I want you guys to think about that for a moment. We, as the largest health system in New York State, have made it a point that every single touch point in emergency medicine, ambulatory care, or inpatient care, that you as a patient are given the opportunity to speak to us about substance use and how it may be playing a role in your life. Now let's talk for a moment about motivation. So I want everyone to think what's the difference between moving somebody, and motivating somebody. So moving someone really is short-lived. Clean your room, make sure you come home before curfew, stop smoking, stop drinking. These are demonstrations of trying to move someone to get a quick response. However, is it a sustained response? And was that response really just to satiate our agenda, or did that person really want to make that change? Here comes the word motivate. So motivate is really trying to use the elements of motivational interviewing and other techniques to really gauge what that person's internal generator is willing and ready to accomplish. It's taking the time, and time being a critical word because this is the biggest barrier, that people think it takes too much time. But however, if you look at it and you think you could spark someone else's internal generator, that's where you get the sustainability. That's where you get sustained change that can actually bring someone towards better health, better community health, better public health, and at an industry level, better approach on our part. So let's talk about the brief intervention that falls under SBIRT. And this, again, may sound alien, but when you really look at the 4 steps, this is no different than hypertension counseling or diabetes counseling. So this is actually embedded and taught to us since day one. Now it's up to us to superimpose this onto another disease process. So the steps of the BNI, they're really deep stewed in the spirit of motivational interviewing. On average, our brief interventions take anywhere from 5 to 20 minutes. Again, it's a team-based approach. We try to empower every team member to have some level of confidence to provide what we call is a brief intervention. The 4 steps is raising the subject, providing feedback, both normalized feedback as well as customized feedback, enhancing motivation using motivational interviewing, and then really coming up with a plan. So not us telling them what to do, but really trying to figure out, negotiating with the patient's insight to understand what they're willing and ready to do and partnering with them. The only way we're successful at doing this is if we really look at the stages of change, this model, this behavioral health model, thinking about every single change that we're deciding, regardless if it's health related or not, we go through the stages of change. And if we can respect that someone may be pre-contemplative or contemplative, and understanding that it's really important for us to meet them at that stage as opposed to push them to action and maintenance, well, that's where we're going to start seeing success. Success based on partnership. Success that we're helping to facilitate, not necessarily drive. And the last thing I want to highlight when it comes down to motivational interviewing is that if you have never been trained in this, I promise you, you already have a lot of the sets internalized. The 4 pillars of MI, or the spirit of MI, are partnership, acceptance, compassion, and evocation. All 4 of those words may be very easy for us to define. Evocation people struggle with. It really is just evoking responses from the individual that we have the privilege of speaking with. But just think about for a moment, if you were to harp on the one pillar that would be the hardest for you to portray to a family member, a friend, a patient, a colleague, I would challenge you to work on that. I would challenge you to read up on the spirit of MI and figure out how you can be more compassionate in the way that you speak to folks. Or how could you provide words of partnership and words of acceptance? Or better yet, how can you figure out to be a better listener so that you could keep evoking responses from the individual that you have the privilege of speaking with? This philosophy and theology has been the main core of our mission here at Northwell Health when we're trying to systematically humanize and address substance use. Now, folks, this all served as background, and hopefully it served as an element of or a forum to seek opportunities for your own organizations. However, the reality of the situation is we're currently dealing with another healthcare crisis, a pandemic, if you will, that has shattered the norms of our industry. In March, Northwell Health, along with many other health organizations and community-based organizations throughout New York State and this country, were faced with a new challenge, a challenge which shattered the norms that we were familiar with. I'm going to tell you a little bit about our experience with COVID-19 and hopefully, again, portray an element of hope. Because the one thing that we knew as our colleagues were helping our communities that were struggling with this brand new process that unfortunately no one understood, we knew very well that we could not let individuals dealing with substance use issues fall by the wayside. We knew that one crisis could not overshadow the substance use crisis that has been around for 20, 30, 40, 100 years. So let me just explain to you what our current state was come March, and then I'm going to describe to you and walk you through our process of what we did to ensure that we were addressing substance use as part of usual care, regardless of all the challenges and the hardships that COVID-19 brought to this organization in particular, as well as to our communities throughout New York State. So our Northwell SBIRT program, this gateway to the house of strategies that I've described, it was embedded in 18 emergency departments, 14 inpatient hospitals, and 5 ambulatory sites. And because COVID-19, we were challenged with the request of removing or minimizing staff on site, as well as in-person interactions to meet the social distancing and hospital level CDC guidelines that were being thrown out to us. At current state, back in March, we had dedicated SBIRT health coaches. These are individuals that are trained in the skill sets that I just discussed with you. They are established and embedded in these sites to provide on-site care in real time for patients that may be dealing with a substance use issue based on their screening. We also work very closely with our massive social work and care management infrastructure that supports these protocols and programs throughout the health system where we don't have an embedded SBIRT health coach. So let me just tell you also why it was important for us to keep focused on substance use, regardless of our clear passion for this. But when you looked at the data, which I shared before with you, but in the United States, over 60% of the population has reported, ages 12 and over, that they've used alcohol, drugs, or tobacco in the past month. And 21 million people were dealing with a substance use disorder this past year. Patients, what we found in hindsight, with recent SUD, meaning substance use disorder, were more likely to be hospitalized with COVID-19. And during COVID-19, we saw alcohol sales have tremendously increased, as well as, unfortunately, fatal overdoses have increased locally by 40 to 60%. So to us, both in real time, both fueled by our passion from the past, as well as now in hindsight, looking at the data, COVID-19 was a perfect example of why we can't continue our universal screening and brief intervention and referral to treatment processes for substance use in our healthcare settings. So we sat down as a team to develop a strategy. We said that we need to figure this out because we don't have our on-site personnel anymore. Everybody else on the clinical team is overwhelmed with COVID, like everything else was out the door. Patients and our communities didn't want to come to our hospitals or any hospital because they were scared of COVID. And that somewhat proves true right now as well when you look at the volumes. So we said that we need to develop a remote model to deliver SBIRT services. And really what we were trying to do was provide care not only to patients in need, but also serve as a conduit for our employees, 72,000 employees that may be dealing with a substance use issue on their own. So we removed our health coaches from our sites. We stood up this remote model to support our on-site team members, as well as made it patient-facing, community-facing, and clinical team-facing. We also wanted to, with this model, create an alternative mechanism to the whole house of strategies. Not just have a conversation with the patient to screen them to understand their risk, but be able to understand what the landscape of addiction treatment looked like. Many facilities had to shut down their doors. Many folks went to remote. Many folks were only telephonic. Our team made it a point to call almost every licensed provider within our region to understand what level of services. And we did this fairly often so that we can serve as a conduit of real-time information so that folks weren't stranded and trying to figure this out for themselves. So when we were talking about a model, obviously we wanted to build a telehealth model. If you're not familiar with it, but Northwell Health has an amazing telehealth team that works in partnerships with pretty much every department you can think of. And over the years have been standing up rapidly tele-based solutions so that we could provide the same level of care throughout our regional organization. However, during the time of COVID, and as you can see here, our telehealth team was consumed with requests to stand up. We had exponential increase in number of providers that joined the network for telehealth. So we were at a moment of pause where we had to either decide and hold up until prioritization can take place and the overwhelmingness of what was being forced on our telehealth team started to dissipate, or we could think of an alternative pathway. And alternative pathway is what we went with. We developed a telephonic-based pathway, one phone number that was staffed 7 days a week from 8 a.m. to midnight so that anybody that touched one of our healthcare organizational touch points could call to seek support, conversation, navigation, connection, referral, you name it. We took our in-person services and now created a pathway to do it telephonically. We did change the hours recently based on volume and getting our team members back on site, but I can't highlight what element of support one simple phone number has provided. We blasted this flyer you see on your screen to every emergency department, every inpatient unit, every ambulatory provider. We were put into the mix of all system level communications that were focused on COVID-19 response. We realized that our situation has yielded a pathway that we never even fathomed would have been accepted and utilized. In addition, we needed to figure out how do we document interactions that we're having, be it with staff, be it with community members, family, or patients. So we used REDCap, which is our research database, if you will, in our health system, and many of your organizations may use this. And we created, in the absence of remote electronic health record access, we stood up our own alternative platform for documentation, for consenting, for programmatic evaluation, and for reporting. And this by far served as the spinal cord of this program, because without that clear, concise communication and documentation, I would not be standing in front of you today talking to you about how Telephonic-Based was a success. So let's talk about the numbers. In 6 months, so we took the first 6 months, so March 18th to about September 15th of this year, we had a total of over 1,300 phone calls that either came in, we made, or incoming or outgoing to this phone number. The majority of those calls did come from patients. However, as you can see, a lot of the phone calls were to support Northwell staff or to refer patients to substance use disorder treatment and care. The utilization, we were surprised, but not really. It was majority during weekdays. And as you can see, mainly between 8 a.m. and 4 p.m. However, we did have a good amount of utilization in the evening hours as well as on the weekends. Let's talk about the patient cases. So we had in total 283 cases, and the demographics are in front of you, but I do want to highlight the bottom row of this table, table number 2. When we assess patients using our evidence-based screening tools on the phone, the majority of the patients or family members that were calling for their patients, the majority of them were actually at the higher risk level of that spectrum that I showed you before. The majority of them that were assessed by staff on site as well were on the higher risk of the spectrum. And to us, this signifies an opportunity for us to better educate our team members about how we can start support for substance use disorder, even for the lower risk and moderate risk individuals sooner rather than later. So it is a teaching point. It's something that we're going to be focused on moving forward, is to make sure that our teams understand that no matter if they're on the high end of the spectrum or anywhere on the spectrum, that they can very openly connect them to us. And lastly, let me just show you table 3, which is an account of the services provided. So through telephonic only, telephonic-based model, we were able to complete 162 full screens, 120 brief interventions, and 156 referrals to treatment. I just want everyone to think back a couple of months. Nobody was leaving their house. Nobody understood what was available to them in terms of healthcare in general, because people didn't even want to come for their regular chronic conditions that they're dealing with or injuries. And we were still able to support 156 people in navigating them to addiction care. Additionally, and this is really important because if you've heard me speak about this before, I really focus on the team-based approach. When you look at, we were supporting staff members, and now this is not about their personal substance use, but this is their plight, their hopelessness in trying to help someone standing in front of them. They had an avenue to reach out so someone could support them, so they were not alone. We also saw 91 patients consent to Project Connect, all virtually. And again, Project Connect is our longitudinal care navigation model that we built for the chronic condition that substance use disorder represents. As well as we used REDCap to send out emails with a ton of virtual resources. Like I mentioned before, not all addiction treatment facilities stayed open, not all turned into remote. However, Alcoholics Anonymous, Narcotics Anonymous, many groups did stand up virtual forums, which obviously is very beneficial to our patients and our team members. So I'm going to share a couple of key takeaways, and then I'll stop and see if anyone has any questions or comments. But overall, telephonic-based model has served to be successful for us providing SBIRT services, as well as all the other services in our house of strategies. We were able to minimize on-site and in-person interactions. And as a collateral benefit, looking at the data now, we're seeing that regardless, and maybe because lower patient volume at the peak of this, compared to the peak of this crisis, and our continual engagement via telephonic SBIRT with the sites, we're seeing the highest SBIRT pre-screen rates in 7 years at our clinical sites, meaning our frontline nurses and MAs are screening pretty much every patient that they can, as opposed to what we've been trying to create over the past 7 years. Most patients, like I mentioned before, that did receive SBIRT services telephonically were at the high end of the spectrum, and that's what an educational opportunity for us. And one thing with, even though it was a telephonic-based model or a tele-based solution, and I only had health coaches in 8 EDs and 3 ambulatory sites before the crisis of COVID hit, with this model, we were able to reach every single hospital in our network, every single unit, and every single ambulatory practice just by a simple phone call. We also gave an avenue for patients and families to call in case they wanted to follow up on a conversation that happened during their healthcare visit, something that we've been really craving to do, just didn't have the finances to get it done, but really serving as some sort of post-discharge support structure. That alternative mechanism for the House of Strategies has proven to be successful, especially when you look at the Project Connect consents that we did during this crisis and during the 6-month period. Additionally, as a team leader, I saw a tremendous benefit for my team. It was very demoralizing pulling our healthcare professionals from a healthcare setting and saying, hey, listen, we can't be on site right now. We have to work from home. Very demoralizing. I'm sure everyone on this Zoom call can reflect and understand that. So what we were able to do is give them a broader geography to deal with. So they had to learn what was happening in Staten Island for addiction treatment, as well as out in Suffolk, as well as up in Westchester and their home site. It gave them the confidence to do and deliver telephonic or tele-based services. And also it built up their morale because they were still able to tremendously support people during a time of global crisis. Additionally, our human resources and employee health started to flip our telephonic SBIRT number out to employees as a central touch point for any one of our 72,000 employees that may be dealing with the substance use issue. So we became the conduit for employee health as well with this one phone number. Future directions, well, like I mentioned, education, engagement. We just have to keep talking about this conversation and enhancing our understanding and skills. We're in the process of implementing electronic referral pathways, so folks don't even need to make a phone call, but through the EHR, they could just do an automatic consult. I'm very happy to say that our amazing telehealth team has worked with us, and we prioritized a telehealth or video-based SBIRT solution, which we should be standing up in a month or two so that we could use our vast telehealth network and video-based conferencing. And then obviously we want to do more studies to understand patient experience and provider experience and so on. So with that said, our CEO says this all the time. Mr. Dowling always says that crises demand innovation. And though we went back a few steps in life and went back to telephonic for a moment, I'm proud to say that telephonic SBIRT is a sustained element of Northwell's addressing substance use portfolio, and we're looking forward to expand and share our lessons learned with our fellow colleagues throughout this industry. I want to thank you once again for the privilege and the honor of representing our team, as well as speaking to you today. Thank you.
Excellent. Thank you very much, Dr. Kapoor. We received some private messages from folks saying how wonderful your presentation was, so thank you for that. We're going to enter into our Q&A portion of the session. We did receive a few questions that came through, but of course, feel free to submit your questions through the chat function. So the first question is from Stephanie Ball. Her question was, where are we going with mental health and medication-assisted treatment? There is still a gap or wall for those with underlying mental health issues that hit a brick wall in getting medication needed for their well-being. Programs are good for new individuals facing addiction. However, those who want to continue with MAT but need other medications to work and be a productive member of society. If they cycle through the meds okay to take but find that none of them work, doctors just say there is nothing else we can do, as the other meds used for those without addiction history are not available to them. This keeps the individual struggling with serious mental health barriers, and they are more likely to relapse because of the bleak outlook on their future. So the question was, where are we going with mental health and MAT?
Yeah, look, I think it's a really important question, and I'm happy that it's posed. And I will just say that though today's conversation was hyper-focused on substance use in particular, the thought process is not that we replace the behavioral health or mental health crisis with a new one. The thought process is that we figure out how do we collaboratively support that patient regardless of what their needs are, be it health-related or behavioral health-related, and create these pathways that are team-based and respectful to the suffrage of that patient. So I would just say very briefly that I would say we continue to stand up the same kind of processes for folks dealing with mental health disorders or mental health issues, the same that we're trying to stand up for substance use issues. We don't need to reinvent the wheel. A lot of what we're doing is really based on common sense of what we've done for heart disease and pulmonary disease and other chronic conditions. I hope my presentation did not discount the value of behavioral health in this equation. However, I do think there's tremendous synergies and a great opportunity for everyone to start working closely together, just like New York State OASIS and New York State OMH and New York State DOH are modeling, is that we work together so we could take care of the person as a whole, as opposed to just individual disease processes.
Okay, thank you. The next question is from Joseph Kelly. He said the number of calls that you put on your slide was 1,347. Total cases was 283. What is the definition of a case, and what happened to the other 1,064 callers?
Yes, thank you very much, Joseph. So in thinking about the way the data was represented, the calls include incoming calls as well as outgoing calls that we make. So in total, for us to justify staffing for the hours, we took account of every single time that phone was being utilized. The incoming calls could have been from a staff member or a patient or a family, or as well an SUD treatment provider, as well as the outgoing calls from my team could have been back to the patient, to the family, to the Northwell staff, or the substance use disorder treatment provider. So that first table really was accounting for all calls, but in total, when we look into it, it's 283 individual unique patient cases that our team dealt with during that 6-month period.
Okay. The next question is from Felicia Parker. What did the follow-up look like for the referrals to ensure patients connected with services?
Fantastic question. And this goes back to one of our higher level services within that house of strategies of Project Connect. So, you know, one of the downsides of SBIRT, and this is industry wide, and what we've been trying to figure out for the last 7 years, is once someone leaves our clinical settings, regardless of how thoughtful of a conversation we did, regardless of how hard we tried to connect that patient to care and made an appointment and got an intake done, we never had the capacity to really understand what happened outside of the 4 walls of our clinical setting without a lot of consent forms, as well as patients' will to be longitudinally followed. Project Connect, now when we enroll someone into Project Connect, we actually have a protocol where same day, next day, 7 days, 30 days, 60 days, and 120 days, we have outreach from our external navigators to support that patient and to help guide them or facilitate their care. So for the 91 patients that did enroll in Project Connect, those are the only ones that I could speak of what happened after the referral to treatments, because if they were engaged with Project Connect, we had the ability to continually engage them as well as the treatment providers. I don't have the data on hand about those 91 in specific, but I will say for Project Connect, we have been looking at engagement to care rates at 30 days of close to 60%, and at 90 days, close to 55, 60%. This is all obviously based on who we can still keep in touch with. So there is attrition from who we consented to who we can keep in touch with. Engagement to care rates really prove to us that constant, continual, compassionate care navigation will help patients on their journey towards well-being and recovery for this chronic condition.
Excellent. The next question is kind of interesting. It's from Suzanne, I think, Tisney. She said, what will you do if the New York State Department of Health eliminates reimbursement for telephonic services versus telehealth? Now, the governor did sign into law back in June or July a bill that audio-only telehealth would be allowed going forward, but we just haven't seen from the agencies how they will intend to roll that out from a reimbursement perspective. So it will be allowed, but reimbursement's a different conversation. So if the reimbursement factor is eliminated for telephonic services, what would Northwell do in that regard?
Fantastic question. As you can see, there is nothing about billing or finances in the slide set.
Yeah.
So billing for SBIRT services still is a big question mark for many around this industry. We also have done many pilots over the last 7 years on trying to bill successfully. Regardless of the qualification of our team members, or if they're licensed physicians or ACPs or nurses, there still is a struggle in getting SBIRT reimbursement, even though there are codes available. Our model has been very financially separated from the whole conversation of reimbursement. We needed to keep growing, and we couldn't depend on financial stability from billing. So I'm not the best one to respond to what happens if telephonic services get devalued or aren't reimbursed, because our model really has never been focused around sustaining based on billing purpose, by billing. It's been seeking grants as well as organizational funding to keep this program going.
I think many of the folks on the line are in a very similar situation. The next question is from Luke Meissner. It looks like he posed this to the entire group, but I am going to ask it. He is trying to set up a virtual mental health and SUD treatment portion of MAT for a pain management clinic to internalize it. Is anyone aware of organizations providing telemental health treatment that he can integrate into a pain management clinic instead of having to refer out?
I would say that's a $7 million question. We're also having the same conversations of looking at the intersection of pain management, of substance use disorder, and of mental health. And it is a complicated conversation because we know, and everyone knows, on first pass, there's no easy answer. However, it is an opportunity for us to explore. I would just suggest to the gentleman that made the question to reach out to New York State OASIS and really understand what capacity certain licensed providers have to be incorporated into some sort of tele-based model.
Okay. And the next question, and this is the last one so far, Lisa Perry said, I think it was very innovative to use REDCap for documentation during the crisis. Are you planning to move this documentation process back to the EHR if the phone line continues?
Yeah, thank you very much for the question, Lisa. Absolutely. So this really was a workaround for the time being. We've already started to move, or I'm sorry, not move, but to utilize documentation that we already had built in the EHR now that we have the capacity for remote access for our team in particular. I just want to be clear, remote access for our EHRs was always available, but it was never utilized by my team in particular because they were always on site. And then when everyone moved to remote, there was obviously a lot of difficulties in technology and getting people access in real time because the whole system was overwhelmed. Now, any touch point that we have with the patient and their chart is still open, we're documenting not only in REDCap for programmatic evaluation purposes, but we're also documenting in the electronic health record so the whole clinical team is aware of what transpired from the phone call.
Excellent. There are no more questions that have come in, and we are at the top of the hour. So I want to thank you, Dr. Kapoor, for your session and for kicking off our virtual telehealth conference. I appreciate everybody on the line who submitted questions. Dr. Kapoor's contact info is on the slide here if you're interested in reaching out to him. The slides, as we mentioned at the beginning, will be placed on the conference website, and the recording will be placed there as well the week of October 9th. So check back at ahihealth.org/2020 conferences to find all of that archived information. We hope that you'll join us at 2 p.m. today for our next session, which is compliance with Part 2 regulations in telemedicine. And we will hopefully see you later today. Dr. Kapoor, thank you very much and have a wonderful day. Goodbye, everyone.
Thank you very much for having me.